Good afternoon. Thank you for attending this month's OCHIN Grand Rounds. I am your host, William Pinnock, and today it is a thrill to have Dr. Erika Cottrell of OCHIN and Oregon Health and Science University and Tiffany Prescott of OCHIN as they present on elevating patient voices through the Health Experiences Research Network. Dr. Cottrell holds a joint appointment as an investigator at OCHIN and as an assistant professor at OHSU. Dr. Cottrell's primary areas of research include social determinants of health, health equity, maternal-child health, patient health experiences, and health policy. At OCHIN, she is involved in research projects focused on understanding the impact of community and individual level social determinants of health on healthcare outcomes, developing and testing EHR-based tools for identifying and addressing social determinants of health in community health centers, and evaluating the impact of payment reform and policy changes on reproductive healthcare utilization in safety net settings. At OHSU, Dr. Cottrell serves as the director of the Health Experiences Research Core for the Oregon Clinical and Translational Research Institute. Tiffany Prescott is a research operations specialist at OCHIN and holds an MS in Communication, a graduate certificate in Gender, Race, and Nations, and a Bachelor of Science in Community Health Education from Portland State University. Tiffany has contributed to the work of the Health Experiences Research Network in several capacities over the past 3 years. Her work has included study coordination, developing, implementing, and leading online and community-based recruitment efforts, significant contributions to the design and launch of www.healthexperiencesUSA.org website, and helping to establish HERN's Digital Presence Subcommittee, a group of HERN members working to establish a digital presence for the network. This session is being recorded. Attendees are unmuted upon entry, but if you are not, please mute your microphone and pose your questions through the chat box. This presentation will last approximately 45 minutes with 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Cottrell and Tiffany Prescott for Bringing Patients' Voices to American Healthcare, an innovative approach to understanding and disseminating patient health experiences. Dr. Cottrell, over to you.
Thank you, William. Okay, let me try to share and make sure it's going right before we start. How is that looking? Are you seeing the screen that you're supposed to see?
Seeing the screen and it looks perfect.
Awesome, great. Thank you everybody for coming today. Tiffany and I are super excited to share with you a lot of the work that we've been doing over the past several years. Bear with us if we screw anything up with related to the slides and being on screen and on video at the same time. So we practiced this morning. I think we've got it, but fingers crossed. So this is William already introduced the two of us. We'll both be speaking today. I also, before I start, first let me tell you what we're going to do a little bit, and then I do want to acknowledge all of our other team members who contributed to this work and who have continued to contribute to this work. So in short, the things that we want to do today is we're going to talk a lot about our work with Health Experiences Research, which is based on this DIPEX methodology. I'll tell you what that is. So don't worry about the acronym. We're going to try to show you some examples of what we've been doing in the US around this health experiences research and the creation of our website for dissemination which is called Health Experiences USA. And then we'll talk about potential uses for this work with some examples of how it really can be used to enhance research, and then thinking about some future directions. And here is something I don't want to start without saying is just acknowledging our amazing team and the funding that we have received over the last several years for this work. So we have a team of people at both OHSU and OCHIN who have been involved with this from the beginning. And I would also like to just acknowledge the funding support we've received for this, starting out with some funding from the Department of Veterans Affairs, Health Services Research and Development Branch. I got a small ARC RO3 at OCHIN early on and worked closely with Molly Crankary on kind of thinking, is this approach feasible within OCHIN? And then we were lucky enough to get some additional funding through Oregon Clinical and Translational Research Institute, which is funded by NCATS, to really build out this work even further. And last but not least, PCORNet has contributed through the Advance project just in terms of helping to supplement this work and our approach to engagement in research. All right, so I'm going to take you on a journey of how all this started and kind of let you know how it came to be in the US. And really, some of you may have heard this before, I always like to start with the story of Anne McPherson, who was a general practitioner and a researcher at Oxford University. She was heavily involved in the Cochrane collaboration, which does systematic reviews of medical evidence. And she herself was diagnosed with breast cancer. And despite being a physician and a researcher and a systematic reviewer, she found that although she had, like, at her fingertips, tons of research on different treatments and the clinical outcomes, she didn't have a lot of information on what it was like to be a person going through this process. And she really noted a gap. This was back in 2001. This was quite a while ago. And what happened from there is she partnered with some researchers from the Health Experiences Research Group at Oxford University. And the idea was born of this idea of having a database of individual patient experiences. And I'll explain how they did this in a second. The original hope for this was that they could have a way of really bringing together patient stories of their health and illness experiences and creating resources that could be supportive for patients and caregivers, that could provide more information for healthcare providers about what their patients were going through. So that really in the beginning was the original aim, that we were going to use research methods, as I'll talk to you about, to gather patient experiences in a rigorous way and then find a way to communicate that back to patients so that it can be helpful to them. I sometimes like to think of it as like a systematic review of patient health experiences, akin to the way folks do systematic reviews of medical evidence. So how is this done? Like, what's the methodology for this? So the way they've established is that for each health condition, say you want to look at breast cancer experiences. So for that health condition, researchers would conduct between 30 and 50 interviews. When you do that interview, you go sit down with the patient, often in their home. Now during COVID, we're doing these all remotely online. But often you would sit with them in their home and you would have them tell the story of their illness, starting wherever they want to start and highlighting the things that are most important to them. And that's really one of the key differences of this approach, is that you have them start by telling their story. And sometimes that takes 5 minutes, sometimes that takes an hour and a half. And you really try not to interrupt, and you sit back and you listen. And then you follow up with other follow-up questions to help pull out different parts of their story. Really, the aim is to represent the broadest possible range of experiences. So we try to engage in maximum variation, where you're getting breadth of experiences and not just the most common experiences. And interviews, it will continue until you reach saturation or no new ideas or experiences are voiced. Apologies if you hear my puppy in the background. Somehow the kids put her in her crate and then went to their class, even though they know I'm presenting. So she may be making noise. So a key feature of this approach is that, I guess I'll go back to this slide. Someone might say, well, that's like typical qualitative research. What's really that different about this? And there are many aspects of it that are very similar to a qualitative research study. But I think, as I've said before, that one of the key features of this is that the commitment to broad dissemination. So all of these modules, which a module, again, is sort of a collection of interviews around a given health topic, are turned into something that could be disseminated via the web. So themes and variation are sort of synthesized across interviews. I'll show you some examples of this later, and turned into topic summaries in lay language that are disseminated via a website. And the UK website was called healthtalk.org, which started in 2001, and they've now done more than 110 different modules. I think that number is quite a bit more even now. And another unique aspect of this is that all of those interviews that were conducted, so de-identified transcripts, are retained, and folks can ask to utilize those for secondary analysis with permission. And then they also do publish in the peer-reviewed journals, which is typical for research. But I think what's really exciting about this is that the focus of this work is really starting from the public dissemination. And that is primary, front and center. So based on the success of this approach, as I said, this started in 2001 in the UK. I think it's up to 15 other countries now have adopted this approach and have their own DIPEx chapters. There's actually an organization called DIPEx International. The web address is up on the top, and you can take a look if you want. They meet each year to sort of share best practices and learn from each other. And in 2014, we were fortunate to sort of launch a chapter here in the US. This chapter was launched as a partnership between researchers who came together, folks from University of Wisconsin-Madison, some Johns Hopkins University, OHSU, University of New Mexico, Utah, and Yale University. You can see the sort of stars of where everybody had come from, of the group that helped to get this kicked off. We established a steering committee. We all came together not knowing each other at all, but all having a common interest in this work. And we were trained by the UK group in how to do this in the US, and then sort of put together the steering committee to try to start doing it. So I had the fortunate opportunity to be part of that original steering committee and helping to launch this group in 2014. We have since then gotten funding from a number of different sources to do these modules. We have 3 completed modules that are available on our website. One on depression in young adults, one that I led on veterans with traumatic brain injury, and another on cancer risk that runs in families. And we have a bunch that are in process, 3 of which have involved recruitment, both at OHSU and at OCHIN. One on childhood experiences of childhood cancer, where we're interviewing the parents or caregivers of children who have been through cancer treatment. Another that we're just kicking off recruitment for on adolescent and young adult cancer. And then a third that we're also just kicking off recruitment for is going to focus on opioid use disorder with a real emphasis on experiences with medication-assisted treatment. And for that one, I'll just give a quick shout out on that one that OCHIN is actually leading the recruitment on that one. And we're going to be doing quite a bit of recruitment in our community health center clinics. Molly Crankary, who's an RA on the project, has been doing just a fantastic job collaborating with a few of our health centers to figure out how to identify and recruit patients who are willing to share their experience with OUD. Other ones that are ongoing, you can see here on the screen, and there are also a number of pilot projects that are underway, trying to see if we want to develop those into a full module. And as you can see, each one of these is sort of funded separately. So the 3 modules we're working on right now, we're really funded through our CTSA, through Oaktree. And others have been funded, I think, through the UW-Madison CTSA, and the VA has also funded several. So we're continuing to look at diversifying our sources of funding for these modules and maybe looking at other foundation sources of funding besides just these big federal kind of infrastructure grants. All right, so we also, as becoming a network, launched our own website. Each of the countries has their own website to disseminate their findings. And here I just want to majorly call out Tiffany Prescott, who was integral to designing this website. We really started from scratch. And as I'll show you, there's a lot of stuff that goes on here. It's more than just creating sort of a homepage. There's sort of a space for sharing video clips and audio clips and lots of complexity. So now I want to show you just a little bit about what's on that website, and I'm going to give you some examples of what it looks like so you can kind of get a sense. And I'll show you some examples from the module that we have on veterans with traumatic brain injury. I was actually going to go to the site, but I got a little nervous about navigating back and forth. So instead, I have some screenshots, but you're welcome to go to that site anytime and look around a bit more. So this page is really like, this is all about like how we do it. And I think one thing that Tiffany really helped us with, and why I wanted to show this one here, is she really helped to make sure that our website is very patient facing. As I'll show you throughout, we found lots of different uses for these materials, but really at the core is making sure that it's relevant for patients and caregivers. And so we do have a methodology page that goes into sort of the research methodology of how we do it. But we also have this page that sort of tries to break it down a bit more in lay language around how this works. And so you can take a look at that more if you'd like on the website, but I just wanted to call that out. So I'll show you here what a sort of, I keep talking about this module. So like, what does a module look like? And this is a screenshot of one on traumatic brain injury with veterans. This is one where we interviewed 38 veterans who had sustained a TBI. And we tried to talk with the widest range possible. And each of these will have an overview page sort of describing what that project was about. And then if you look on the left-hand side, you can see this navigation menu. And what happens in these modules is there's usually about 25 sort of little summaries that describe different aspects of the experience and try to synthesize the experiences across the interviews and to highlight both the common themes, but also some of the variations. So we try to make sure that we're at least representing all of the experiences that we've heard about. And so each of these, if you look under here, this is a category under, if you clicked on nature of injury diagnosis, as I'll show you on the next slide, there's 4 different summaries. Under living with TBI, each of these represents a different summary, and I'll show you an example of that. So this is under, if you were to look under on this menu, if you were to click on nature of injury and diagnosis, there's a few different summaries: how injury occurred, first signs something was wrong, evolution of TBI awareness, and TBI screening and diagnosis. And each of these are about 300 to 1,000 words of actual text. We try to put forward, have less text and more from what we heard from patients. So they have 300 to 1,000 words of text and really try to illustrate what we heard from the different patients on this topic across the interviews. And those are illustrated with clips from patient interviews that are generally, could be anywhere from 30 seconds to 5 minutes long. And those can be in audio, video, or actual text format, depending on the patient's how comfortable they are with that. So you can click and hear what they had to say for each of these. And this keeps going down. You can scroll down and there's more words and then more videos. I just wanted to show you some of the other summaries that come about. We go through not only the nature of the injury and diagnosis, but what it's like to live with a traumatic brain injury. So we have these different topic summaries here. This one was a lot about the changing sense of self, not being able to do what you once could. We look at topics around coping and support. How have people coped with their injury? What are the things that have been most helpful for them? And then really there's another section too on sort of their insights and looking forward and their advice for other veterans, which I think is one of the most fun ones to put together and one of the most fun ones for people who are talking with us. We ask each person, what would they want to say to someone else who's in their situation? And people have lots to say. And when asked why people are doing this, most of them have said, because I really want to help someone else. I want my story to help someone else. If by sharing my story, I can be of use to someone, that's what I want. So that's been a really sort of gratifying part of that, is to really bear witness to these people's stories and help them find a venue to share it. Here's an example of some of the advice for other veterans that people were giving. I guess one more thing I'll say about these boxes, if you'll go on the website, you'll be able to see it. Each one has sort of a strap line here, what says like, Stephen encourages other veterans to notice when something's not right in your life and seek support from the VA. Frank doesn't want other vets to go through the same things he did and encourages them to seek benefits at the VA. That tries to give a synopsis of what they're going to see in the clip, and you can click to play on the clip, or you can click and sort of just see the text of the clip as well if you don't want to listen to the video or don't have that capacity. And then if you want to hear more about that participant, you can actually click here and it can go to a full profile of that participant. And I'll just show you one example of that. So if you click on a given person, it gives you a little the age of that person, a little synopsis on them, the background. And this one we really focused on their military branch. For others, it may be different background characteristics you want to hear about. And then there's sort of a more full synopsis of their experience. And then every clip that's included in the module is here on that person's page. So with all of that, I know that's a lot to digest, but I wanted to give you a sense of what all is in that website. So we started with like in the beginning, that was 2001. As we all know, like things have changed quite a bit since 2001. I think in 2001, I had barely dial-up internet at my house. I didn't have a smartphone. I don't think I even owned a laptop yet at home. I think I got one in 2001. So this was like the dawn of the, really the internet. And it was pretty innovative to share patient experiences on the internet via video. And now we might say, like, is this still relevant? We have all of this stuff out there. We have these patient experiences blogs. We have YouTube. We have social media. There's sites like Patients Like Me. There's a proliferation of sites. And is this approach still relevant? And I think that we are still grappling with this and trying to make sure we are able to really articulate that and also keep up with things that have happened in the environment and with technology. But I would argue that DIPEX still remains really the only site that I know of that's based on rigorous qualitative research, and that is really not having an agenda in terms of the viewpoints that we are trying to share. It's not all about promoting the VA. It's not all about promoting a certain cancer organization. It's not all about making OHSU look good or OCHIN look good. It's about really understanding these patient experiences regardless of what they were. And so I think that's one thing that's really innovative about this approach. Another is that there's multiple uses beyond the original ideas. And I'm going to give you a couple examples, a bit more of that. This is something that Tiffany put together as well. And I think that we use this when thinking about our website, that, patients are first and foremost on our mind in terms of the web production, but we're also really trying to reach other audiences. So, families, caregivers, and friends may find this information really useful in helping to support their loved one. The general public even may find it very useful in terms of understanding what it's like for certain people with conditions that aren't talked about as much. It can also be used for advocates, for healthcare professionals, and for funders. I think in regard to the healthcare professionals in the UK, actually these modules are used in upwards, I think, of 80 to 90% of medical schools use these in their training to help give trainees and students a broad understanding of the types of patient experiences that they may encounter, and all of those things that are happening outside of the exam room. When your patient comes in and talks to you for 15 minutes, they're not going to have time to tell you all of these other things that are going in their lives. So it can be a really good way to get an understanding of that. And then lastly, and something I'm going to talk a little bit more, I feel like they're really useful for researchers. This is based on research. And this information is very useful for research, in that we have this treasure trove of transcripts that can be analyzed for secondary use. I think already we have close to 300 interviews across all of the network, and it's growing every day. And then I think what I'm going to talk about a little bit here is that we've talked a lot in research lately about how better to incorporate patient perspectives into our research, how to really conduct research that matters to patients. That's a lot of the whole mission of PCORI, the Patient-Centered Outcomes Research Institute, was recognizing that, a lot of times our research doesn't have impact, and we need to figure out how to make it more relevant to patients and to really include their perspectives in research. And that's kind of led to a real increase of patient engagement in research, which is so fantastic. That we really recognizing that if we want to conduct research that matters to patients, we need to understand what's most important to them, and we need to engage them. And I've often argued that this could be this HERN, this health experiences research approach, is another way to augment that patient engagement. We have a lot of times now on studies where we have a patient investigator or a patient advisory panel, and those are amazing things to do. And this could be yet another source of information. When you have a patient on an advisory panel, that's sort of one patient, and they couldn't possibly be expected to represent the entirety of patient experiences. And by utilizing the HERN resources, you could get a better sense of a broader range of patient perspectives and patient experiences. And I'll show you a little bit more about that in a second. I also always like to come back to this. I mean, we talk about this a lot in the research that we do at OCHIN. And it's just sort of recognizing this ecology of medical care article, and how, for every 1,000 persons, you can kind of look down 800 report symptoms. 327 consider seeking medical care, 217 actually make it into an office, and you go down all the way down, less than one are hospitalized in an academic medical center. And yet so much of our research takes place in sort of the hospital academic medical center setting. We at OCHIN are really trying to move that out to the community and do it in the community health center setting. And I think where this HERN approach comes in is it takes it even one step back to really understanding patient experiences outside of the health clinic and even among those who haven't yet engaged with healthcare. So before I hand it over to Tiffany to say a little bit more about some of the work she's been doing, I just wanted to talk a bit more about how we have been trying to think about utilizing this for research, and also how I really sort of give you a little bit more meat around how it really is an approach that can be used to enhance patient engagement and to sort of amplify patient voices in research. This was behind a lot of the funding that we received through the Oregon Clinical and Translational Research Institute, that we really argued in our application that this approach is really integral. We really could be utilizing these resources that we're gaining through this methodology to really inform research across the spectrum of clinical and translational research. And I'm just going to talk a little bit about these three aspects of HERN. And these three, I think, when thinking about it, a lot of the questions, like what is different about this? Why does this matter? How could it help our research? How could it help amplify patient voices that's different than things that we see on social media or other blogs or other patient sites? Is that I think it really boils down to these three things and more, but I'm going to talk about these three things because we don't have unlimited time. But I think really that central to HERN is listening to patients. Listening. That's the first objective. We are listening, and we're aiming to capture a wide range of experiences and priorities, including those that are often not heard or may not be included in research typically. I think it's a source of where we can empower patients by giving voice to their story and also choices about how it's shared that I'll tell you about a bit more. One of the things I heard from the veterans I interviewed is that often they just want to know that when they sit down with us for 2 hours and share their story, that it's going to be used for something. They really want it to be used. That's why they're doing it. And so I think this approach has several ways that can be used. I also think it goes from voice to voices. So it's not relying on just that single voice, but synthesizing many voices. And beyond that, really disseminating to broad audiences beyond just the scientific literature. And that's the point that Tiffany's going to talk about a bit more. So just a couple, I'll exemplify this just a bit more for each of these points. This is just a subsample of some of the folks we interviewed for the TBI module. But again, we sit down with people in their homes or in places that are most comfortable to them. And these days, that's all on Zoom, which actually has been a great innovation that was forced upon us by COVID, but I think is one that we may end up keeping, because in terms of reaching diverse patient populations and those who may not have other means of contributing, actually being able to do this remotely, I think is enhancing the way that we're able to get some people. There may be people that don't want some researcher coming in their house or that don't want to go do an interview in person, but may be willing to do it on Zoom. And I've been pleasantly surprised with how that's worked. I think another thing about this is that it's again, we're really trying to get the widest range of possible experiences. So we're always kind of coming back to who we have and who we've talked to and who we're missing. And continually reflecting on that. Are there voices that haven't been included? Are there people, are there subgroups that we're missing and that we haven't reached out to? With the veteran module, we found at first we were getting a lot of Vietnam vets and older vets. We started our recruitment at the VA and then realized that if we wanted to get the younger vets who were, say, coming back from Iraq and Afghanistan, they weren't always at the VA. So we started to expand our recruitment out into the community a bit more, went to community colleges, went to Portland State, went to some veteran fairs and events, went to some sporting events that had veteran nights, and actually partnered with community organizations to get the word out a bit more broadly. So as I've touched on, I think part of the way that we get this wide variety of people is we really prioritize using a variety of different recruitment and engagement methods. So we definitely will do the traditional clinic-based recruitment where we're sending out letters from providers, putting flyers in hospital-based clinics. For our study on childhood cancer, we did a ton of that. But we're also trying to partner with community-based organizations, as I said, working through social media and other online forums to recruit and posting flyers in key areas throughout the community. And I think another exciting thing that we've done in partnership with OCHIN is we're really trying to partner with OCHIN clinics to do some of this recruitment in their community health center so that we're getting beyond the hospital and more into communities. And I'm going to pass it over to Tiffany for a second, and I have her talk a little bit about how we're also using each module has a stakeholder advisory board that helps to advise the process of the module, and how we're using that group to help with sort of the recruitment and making sure that we're reaching the right patients. And then she's going to give a couple examples of our recruitment strategies. So over to you for these few slides, Tiffany.
Thanks, Erika. So yeah, as Erika mentioned, I think that one area that's been really exciting in terms of evolution for our study team has been refining the way that we approach and work with our stakeholder advisory board. So if you go to the next slide for me, Erika.
Yes.
Thank you. What you're seeing here is our kind of traditional recruitment methods, and this would be a print flyer that got handed out in hospital or clinic settings. Oftentimes providers were able to give that to patients. This was the bulk of our recruitment efforts for this particular module occurred before the pandemic. So we really were interviewing patients and families in their homes. And so a lot of our materials were designed with little tear-offs and that sort of thing. And our stakeholder advisory board was really great because they helped develop these materials and make sure that they were appropriate for families to receive, that they would feel comfortable for some of the folks who are providers themselves, giving that out to their patients. And they also were able to help us pivot our recruitment efforts when we weren't able to do all of that in clinic and hospital-based settings. So we did engage some community-based organizations later in our recruitment efforts, and we are actually still working with community-based organizations to recruit the last of folks. As Erika mentioned, we want to make sure that we're capturing all the voices. And so we've had some help identifying who we're missing, and we're trying to get some of those folks in a last push around recruitment for this one. Do you want to go to the next slide? For our AYA or adolescent and young adult cancer study, we recognize that this is also a different audience. For childhood cancer, we were really focused on families, but the patients themselves aren't quite old enough to go through the interviews. Some of them are at the upper end of the age range, but for the most part, we're interviewing like parents or caregivers, different parts of the family. But for AYA, this is the patients and survivors themselves who are giving these interviews. And we've shifted our recruitment efforts, at least at OCHIN, largely to an online and community-based setting. So what you're looking at on the screen here is an example of some of the digital flyers that we're using in our social media campaign. And we've also included these digital flyers along with a few more that don't fit on the slide. We've packaged it with instructions for use, some sample captions, some instructions for tagging the HERN social media accounts and linking to the online eligibility screener in what we call our social media toolkit. And that toolkit has been distributed to our community partners to help promote the opportunity to participate in the study. And with our stakeholder advisory board, we've shifted gears into really identifying a few key roles for the advisory board members. And so we are engaging a couple of recruitment advisors who are also tapping into their networks, helping to refine these recruitment materials. They weighed in on everything from language to the imagery that we're using. A great piece of advice that we got from one of our stakeholder advisory board members, the recruitment advisor, was to be careful about where we're using some of the clinical imagery if we're targeting survivors who are coming to us from a community-based organization that's focused on survivorship. So to sort of separate that clinical setting. So we have a wide variety of images then to help make sure that that's appropriate for the audiences that they're reaching. So that's been really exciting. And then if you go to the last slide in this section, for our opioid use disorder and medication-assisted treatment study, we sort of, we've engaged many subject matter experts and folks that we hope to join, SAB and work with us in that way. And really, through those conversations, have recognized that topically, we just need to use a different approach for recruitment. So it might be appropriate for childhood cancer, AYA is not necessarily appropriate, kind of recognizing the sensitivity and privacy concerns around opioid use and treatment. And so for this module, as Erika mentioned, OCHIN's leading the efforts, and we're really focused almost exclusively on clinic-based recruitment methods. And so what you're looking at is our information sheet that we're providing to clinics. So if there are any clinic members that are interested in helping us recruit patients to this study, we can hand this out to you as well. But we're asking clinics and providers to really partner with us to help identify patients and to just treat the process of getting through the eligibility criteria and that sort of thing in a really sensitive and appropriate way, and also to be responsive to patients in a different way than we maybe can be if we're disseminating a screener that folks take online and respond to like in bulk. So that's just a few ways that we're varying our recruitment methods, topically engaging our stakeholder advisors, and producing materials that are appropriate for each module.
Thanks so much, Tiffany. That was fantastic overview. And just a couple more points that I wanted to share in terms of sort of the uniqueness of this method and the continued relevance is really, the idea of empowering patients by giving voice to their story and choices about how it's shared. As I've said before a number of times, so I won't get into it a lot again here, but there are multiple uses for these. We really disseminate them via the Health Experiences USA website, but there's also de-identified transcripts that are stored in a data repository, and that can be used for secondary request. We make sure, and the UK really did a good job of modeling this and setting forward this model that's really worked for them, that patients have control of what data is shared and how it's shared. So each of them signs a future use form that talks about they have a chance to review their transcript and they can remove anything they want to take out. And then they get to choose if they are open to having video clips, audio clips, or they want it to be de-identified written clips that are shared. And they have the opportunity to always revoke that later, so that they could, say they give permission for this woman gave permission for her video image to be on the website. She could come back a year later and say, no, thanks. And we would take that down. We have to explain to people that, that once it's up there, it's hard to know that it's completely down everywhere, but we really want patients to feel that they retain control of their material. I wanted to show you this quick video. It's only about 2.5 minutes long, but it really, I think, exemplifies again how patients feel about being able to share their story and have it matter and have it be shared with others. For some of the veterans I talked to, they felt that was the first time that someone had really sat down with them and listened to the whole thing. And there's some that preferred not to have their image shared, but they still wanted their story to get out. I mean, that I would say everyone was united by the fact that they wanted their story to matter, and they were really open and excited about that. So I did share my sound, but Tiffany, if you could give me or just say something if you're not hearing it.
I think your sound is sharing, but
I think it's starting
It's
slowly.
really important for people to be able to see themselves
No.
or see part of themselves
Yes.
reflected. And for me, I didn't really have that. Even now, as we're recording, it's trans and non-binary people are very underrepresented. And to have the intersections that I do as somebody who is queer, non-binary, mixed race, I think that we need more people from these intersections coming forward.
If I can provide any help to anyone, I would like to try and do that. Maybe to give a different perspective from someone younger, I don't know, or different, but just, I thought I'd help.
The big things, the understanding of not being alone in it.
Yeah.
There's other veterans out there.
Yeah.
Bueno, pues primero gracias por estar aquí, por tomarse el tiempo para investigar acerca de esto y querer ayudar a más gente a través del testimonio de uno, que espero que sí sea de alguna ayuda para las personas que van a pasar por esto.
Sharing people's experience of what that looks like or how that feels could create a lot of compassion and understanding for people who are afflicted by depression. And that was something that I wish I would have gotten.
For one thing, I don't want these kids now ever to go through the same stuff I did. And a lot of us Vietnam vets are, I can't speak for the whole demographic group, but there's a lot of us that feel the same way. And we're helping these guys coming back.
One of the things, for people like myself seeking education, I think organizations like yours, you put me on the right path. And I think that it's important that for people who are in my situation who want so badly to do something, that there are, my father used to always tell me that education is knowing where to find the information.
We don't hear nothing about cancer until a celebrity's face is plastered. And like I said, like cancer is a celebrity that nobody don't know about.
Right.
Stop using celebrities to talk for us. Yeah. Put us up here.
All right. So the last point I wanted to make is that, we've emphasized just now sort of the idea of folks being able to share their story. And I think what this approach does is it takes that extra step of synthesizing themes and variation across stories and disseminating that out. So I think this is a lot to digest, but I just wanted to kind of point out here that, as this started, it was really intended to be sort of a place for balance and unbiased source of information for patients and caregivers, and a learning place for students and health professionals. And I think that synthesis and then bringing together lots of different voices has really made it so that it can be also a place that can be used for identifying questions and problems that matter to patients and generating future research. I worked with a pediatric oncology fellow this last year who really used the interviews to identify her next steps in her research career. Really illuminate the experiences of patients and caregivers from harder to reach populations that you might not hear from, typically in research studies or through other engagement opportunities. And then other things like informing research on the collection of patient-reported outcomes and really figuring out what's most relevant to patients. And the idea of coming from voice to voice is, I think many of us have seen that really powerful TED Talk about the danger of a single story. And I think what this helps to do is to show those stories, but then bring them together and show a number of different stories. It's really a synthesis. We want to portray the range of experiences, not just the common voices, not just the most common experiences or those most articulate people or the people with the loudest voices. I often wonder too, I think when we've talked about race and ethnicity and racism in our society, that it can really be a way to understand people who are actually very different from us and what their experiences are, and really understand some of the commonalities and differences in a way that we don't often see in our social media accounts, because it's often curated to people that are very much like us. So this is a nice way to kind of break down and work against that. So from there, I want to hand it back over to Tiffany to talk about sort of the commitment to dissemination a bit more and some of the great work she's done.
Yeah, thank you, Erika. So really in our attempt to disseminate and reach broad audiences, last year, a group of us joined forces to create HERN's Digital Presence Subcommittee, or what we call DPS. And this group is responsible for establishing and supporting the network's digital presence, primarily through website dissemination and social media engagement. And really the focus for this work, I think, is on meeting patients and our other stakeholders where they are. So if you go to the next slide, while it's true that many folks find our website because they Google a specific condition and then it pulls up in the searches, we really know that this resource is maximally valuable only if it's actually in the hands of the people that it was created for. And so we're trying to get that into people's pockets, right, into their news feeds. We want to break up whatever else they're scrolling through, all the other news and updates, baby updates, marriages, and that sort of thing, with a little bit of health information, and just remind them that this resource is there should it ever be valuable to them or someone that they know. And so once we got our committee up and running, we really focused on setting up our social media accounts. Right now we're focused on Instagram and Facebook. So what you're seeing is a little screenshot of each of those platforms. And our goal with social media is to promote the work and website for HERN and continue to drive traffic there. And I think additionally, we're really aware that social media can be leveraged to provide education around why having an evidence-based resource like the HERN website is important and why it benefits patients as opposed to other narrative sources that are out there. We also know that this can be leveraged for recruitment efforts and for reaching more people and getting them enrolled to the studies, and also for establishing partnerships so that we have more engagement, that we are able to grow the network and get folks involved in both recruitment and dissemination efforts. Next slide. This one's probably my favorite one in the deck because this, kind of excitingly shows that our efforts seem to be working so far. So what you're looking at is the screenshot of an Instagram shout out from one of our patient participants who had a great experience sharing her story. And this is the type of engagement that we're hoping to see grow via our work and continuing to put efforts into our social media platforms and drive traffic to the website. Next slide. I also just want to put a spotlight on our Patient Consumer Advisory Council, or we call them PCAC. This group is essential for representing patient voices across the network and in all network activities. Their contributions are really critical for keeping patient voice at the heart of this work. And I don't think that can really be understated, or gratitude for having a group like this to work with. In particular for DPS, we really value their input and work with us to increase the accessibility of our digital presence. So that's our language, but also how do we get in front of more patients so that this can be used. So we're continuing to think about how we can bridge the work of our two committees. They're integral to, as one of our key inputs, and just making sure that we always have that patient voice at the center of our work. Next slide. Another way that we're seeking input for the work of DPS is through our recently launched town hall events. So these are bi-monthly semi-structured events in which the HERN community, which we mean that very broadly, it's anyone who has been involved with HERN at any point or is just interested in getting involved with HERN, patient participants, whoever's elected to join a mailing list to hear updates from HERN via our website. Everyone's invited to drop in and bring discussion points related to our digital media. So our website, our social media accounts, and any digital recruitment or dissemination materials that we produce as well. Our next event is in April. So if anyone is interested in joining, you can send me an email. And our focus in this space is about having discussions around, again, increasing accessibility for patients and brainstorming ways to better reach patients. So with that, I'll pass it back to you, Erika, to talk about what's next for her.
Yeah, I just wanted to say a couple words about what's next and what's happening. So yeah, just a few things that we're working on. We're really working on, we're a collection of universities right now, and we're working on creating a sort of a centralized cross-institution data repository for some of the transcripts, or all of the transcripts that are produced with this. And I'll be working on that with the Oak Tree CTSA over the next several years, trying to get that up and running. We're continually growing the network and training new investigators. We've already had 3 trainings, and we're going to have another one coming up that we'll show you a quick flyer for. We're also trying to work on doing earlier collaboration with communities, like talking with communities from the beginning about what they feel is most important, and really thinking about ways to partner with communities and training local interviewers to conduct the interviews. In the RO3 that Molly and I did, we did some work with a clinic in Hawaii, and who said, we'd be into this approach if we could have someone from our community going out and conducting the interviews. But the idea of someone from Oregon, from the mainland, some, unknown researcher swooping in and doing these interviews and taking our stories with them was not appealing. And I think we have another colleague in New Mexico who's finding a lot of similarities. And I think it just speaks to the need to really think about ways to really partner with communities, enable and build that trust and commitment and partner local community members to do some of the work. And as Tiffany said, we're really trying to think about non-traditional dissemination routes and also recruitment, trying to expand how we do this recruitment. Perhaps there could be a way, say for OCHIN patients, this is something we also found in our RO3, that some clinics were like, what if there was a way for them to just opt in to being contacted? Like patients all got a flyer or a note, and if they were interested, they could say, yeah, contact me if you have something. Because right now what happens is each time we have a module, we go to the clinic to see if we can recruit patients. And is there a way that patients could opt in? And in our work with Oak Tree, we will continue to evaluate the impact and use of these modules, discover new innovations, trying to kind of push it forward and make it better in the future. Here's a training that's coming up. Let us know if you could actually it says email Rachel Grabbett with study to you, but you could let me or Tiffany know if you're interested in joining. It'll be virtual. We'd love to have more folks. And also, we want to hear from you. If you have ideas, thoughts, things where you think we should do more, topics you think are interesting, you can always feel free to email Tiffany or myself. And be sure to check us out on our website, on Instagram, on Facebook. We're really trying to build these sources. So go ahead and check those out.
All right. Thank you, Tiffany and Erika. And unfortunately, we are at time. I see that we have a couple extra questions. I will pass these along to Tiffany and Erika, who could follow up.
Fantastic. And everybody feel free to reach out if you have more questions that come to you. We're super excited to chat more and answer any questions you have. So thanks for your attention and for attending today.
Thank you, Dr.
Thank you.
Thank you, Dr. Cottrell and Tiffany, for that fantastic presentation on HERN. And thank you to everyone who attended today's session. Be sure to follow the latest developments and modules from HERN at healthexperiencesUSA.org and follow OCHIN on Twitter at OCHIN and over on LinkedIn. In addition, head over to OCHIN.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And OCHIN Grand Rounds will return on April 16th with Dr. Rachel Gold of Kaiser Permanente Center for Health Research and OCHIN, and Arwen Bunce of OCHIN presenting on the study of practices enabling implementation and adaptation in the safety net, better known as SpreadNet. So from all of us at OCHIN, have a great weekend and stay healthy out there.